But yeah, Stan, thanks for the introductions. And I'm really excited to be here with you guys today. I know I got to join in with you guys once last semester as well. So some of you may already know a little bit about my story, so I won't dwell too long on there. I'm going to actually share my screen with you guys here. I have just a few little slides to kind of help guide us through my talking points. So before I talk about me, just a quick introduction to what we're going to be talking about today. I'm going to be talking about the road to resiliency. You know, this is a really hot topic now, right? Is this idea of burnout in medicine. And I know you guys are students, residents, somewhere along that, path where you're still in that learning process. And even though at your stage, we hear so much about, right, especially residents, right, being burned out. But I just want to assure you guys, this isn't your typical, self-care talk. How do I avoid burnout? I'm going to be coming at this from a little bit of a unique perspective and kind of what my path there has been to finding that passion and maintaining that passion in medicine, right? Like we all went into medicine because we were passionate about it. You don't get through all the requirements that you have to get through in college, and whether it's getting into PA school or med school or whatever path you're on, it requires a lot of dedication and motivation and passion. And so, how do we hang on to that in our career? And most of all, how do we let that motivate and drive how we take care of our patients and how we fulfill our unique purpose in medicine, right? We all have a unique calling, a unique reason we went into medicine, a unique field we're called to. And so I really just want to talk about like, how does that passion that got us into this career help us to really find and maintain that unique purpose in a way that makes us resilient against the burnout we see happening all around us, and to stay present with our patients and as well. So that's kind of what we're going to be talking about today. So real quick, again, before I talk about me, I just want to kind of introduce like the concepts of what we're going to be talking about. So what do we mean by resilience? And just some different ideas. There's a lot in that word, but right. So it's like the capacity to perceive and respond well to stressful situations, to bounce back from those difficult situations. I really like where it talks about like to bend and not break under extreme stress. It gives me, for me, I think that picture of that like tropical tree that's really flexible in the like hurricane, storm, and it bends and it doesn't break. To persevere despite ongoing stress, characterized by a set of good outcomes that occur in spite of serious threats to adaptation. So we're all going to face those serious threats. Something, right, is threatening us, or we wouldn't see these high rates of burnout and suicide and the stress, especially over the last year with COVID. We're seeing that, a really extreme level of that. And we wouldn't be seeing that if there wasn't stress. And so how are we going to deal and adapt and become resilient in the middle of that? Is the question. So what are some of the roadblocks that get in the way of us being resilient, right? So I've mentioned burnout a couple times, and I think that's the big buzzword that we all hear. And so one definition of that is just reaction to prolonged chronic job stress, characterized by exhaustion, cynicism, and feelings of reduced professional ability. And I think that's probably something we can all relate to some degree, right? It's very easy in the middle of training when you're studying and working, doing rotations, all of those things, to feel exhausted. And then the cynicism, I know personally, that was something that started creeping up on me very early in my career. As we go in with these very high ideas of our patient relationships and our patient rapport and getting our patients to change and do things. And then that's not always the way it works out, right? In fact, that's frequently not the way it works out. It can be hard to develop a good relationship with your patients. They don't want to listen to you. They don't change. And it can be very easy to get cynical as we see the difficulties in that, right? And then these feelings of reduced professional ability can come along with that for a lot of various reasons. But there's a couple other ideas. And one that I really want us to think about as I go through this today is moral injury. So I don't know if that's a term that you guys have heard of or not before, but it comes up a lot in what I do. So moral injury is this idea of an injury to your conscience. So like we all have this sense of morality of what's right, what's wrong, especially when it comes to our medical practice. And so moral injury can come from an injury to our moral conscience resulting from an act of what we perceive as a moral transgression, that it can produce a lot of ongoing guilt, shame, maybe feelings of not being able to carry on in our career or our, whatever our passion is, and this sense of betrayal, anger, and moral disorientation, even like where it can affect, that strong sense of moral compass that we had. And then, of course, the more severe end of all of this would be PTSD, which is also a term we're all familiar with. But so this is a deep, ongoing suffering that affects us on a daily basis. So it can cause insomnia, guilt, anger, family strife, even all the way to this feeling of no way out and self-harm or suicide. And so that's kind of a range of issues that we can face when we face these traumatic situations that are bound to come up in medicine, especially when we put ourselves in difficult situations in disaster relief or missions. So the things we're going to talk about that kind of can help us have the stepping stones to being resilient versus ending up in those burnt out or even all the way to the extreme of PTSD. I'm going to go into these in more detail, but just to give you kind of an overview of what we're going to talk about is do hard things, go to hard places, bear one another's burdens. And we need to develop our personal philosophy of suffering. How are we going to frame the suffering that we see in the world? Skill mastery is going to be hugely important, that we feel confident and competent in what we're doing. Our healthy personal habits, that's kind of that self-care piece. And then finding your unique purpose, because that's really a huge protection against burnout, is that sense of purpose, that this is what I'm called to do. And this is what I want to be doing with my life. So I'm going to keep forging ahead despite the difficulty. So my personal path. So I'm a PA. As Stan talked about, I trained in Houston, Baylor College of Medicine, and then I worked in the ER full time for 7 years. And that's when I personally started to, see and experience some of that cynicism and burnout and exhaustion and all of those things, and just not having and finding that sense of fulfillment that I was looking for when I became a PA. So about 7 years into that, I made a huge life change, and I switched to, gave up my full-time job and switched to PRN. And so big change from a steady, constant monthly income to not sure how many shifts I'm going to work this month. But what that enabled me to do is work when I wanted to work and not work when I didn't. And so it really freed up my time to do, which I was already doing, but to really focus on doing mission clinics. My church has a lot of mission partnerships. And so I run medical clinics typically in India and Liberia. So these really minimal resource settings, right, where you have to get really creative and you run into a lot of patients and problems that you can't help and you can't fix. And if we have time, I might share a few of those instances with you guys. And then as well, since then, I've joined Samaritan's Purse disaster relief team. So Samaritan's Purse is a Christian evangelical organization that responds to disasters and crisis all over the world. And so that's kind of their main mission, is to be present in disaster to provide physical, spiritual, medical, emotional aid. And they especially have a strong history of responding to infectious disease outbreaks, which is mostly what I've gotten to do. So in 2019, I had 3 deployments to the Democratic Republic of Congo responding to the Ebola outbreak. And then last year, I was in New York at the height of the outbreak there. We had a field hospital in Central Park of all places. So that was a surprise when I joined a disaster relief team. I definitely did not expect to end up in Central Park. And then also went to Alaska and South Sudan for COVID-19 as well. And so, you can see in those, whether it's a mission clinic in India or Liberia, where I have very minimal resources, or witnessing the trauma of Ebola and, the horrors of an Ebola outbreak. Definitely a lot of opportunities there to encounter these difficult circumstances that can cause trauma and cause moral injury. And but it's been surprising to me how that has actually been affected me differently than I maybe anticipated. And so we'll get more into that. But that's just kind of an intro to the topic and to me. But I just want to say that, like, I would love for this to be more of a discussion. If you have any questions, like, please feel free to jump in, comments, all of that, and just feel free to jump in at any point. And I'll try not to do all the talking. So I want to share with you guys a case study, and then maybe if we have time, I'll even share a couple more cases of some things that I've seen. And so I'd love to make this interactive and get you guys involved. So I'm going to ask some questions. So the setting for this particular patient was the Ebola Treatment Center in the Democratic Republic of Congo. And I've got some pictures of that just to give you guys an idea of where we're at. So the Ebola Treatment Center is like a pop-up, built-up treatment center pretty much in the middle of nowhere, Africa, at a place where the outbreak was supposed to be pretty large, it was a hot spot. And so it's just really these wood-framed pop-up, medical care centers is where we're at. So a little bit about an Ebola treatment center. Anyone that meets the case definition of Ebola has to be brought to the Ebola treatment center, right? So that can be pretty broad because early on, Ebola causes very, broad symptoms of, malaise, fatigue, headache, vomiting, diarrhea, fever, right? So think of how many other things that could be. And so anyone who meets the case definition as it's put out by the World Health Organization at any like medical center should be brought to the Ebola treatment center. So we have a suspect area of patients that meet the definition of Ebola, but are still waiting for testing, and then a confirmed area for patients who have been confirmed to have Ebola, because obviously you want to try to keep those patients separated, and anyone who may not have Ebola, you don't want them to be exposed to the patients that definitely do have Ebola. And so they get, isolated care while they're being tested for Ebola to get them out of the community and out of the healthcare centers where they don't have the resources and the training to properly care for an Ebola patient without spreading it to themselves and other patients. So typically our patients came by ambulance from other healthcare centers, but this particular child, it was a 12-year-old male, and he was dropped off at the gate by his parents, and dropped off not in they abandoned him, but they can't come inside. So dropped off at the gate, unconscious with labored breathing. And this was exactly as it was brought to me. So I was at this time the head clinician there. Everyone else was a national doctor. So I was kind of in charge of all the medical care at this point. And so I was not on the clinic side. I was on our living side. And I was, someone came over, hey, there's this kid. They were dropped off by their parents. They're unconscious. They don't seem to be breathing very well. Walk over, try to get more detail. So the child's not arousing to stimuli. His breathing is rapid and shallow. About all the history that we got really out of the parents was he'd been ill with some vomiting for 3 to 4 days, became unconscious this morning. No known past medical history on this kid. The nurses, got all donned up in their PPE and went inside, started getting some vitals. So his oxygen was low, around 86%, kind of hovering around there, a little lower. Respiratory rate rapid, 34. He's tachycardic, 130. His pulse was strong. We weren't able to get a blood pressure. Our blood pressure machines weren't great and were sized for adults. So would anybody like to jump in with some thoughts on what your differential diagnosis could be, what resources or diagnostics you would like? And if you're thinking, I don't know, that's not very much information, you're absolutely right. That's exactly what we had. And so you have to start a lot of guesswork. So if anybody would like to jump in with a differential or something else you'd like to know.
I guess something towards the top of the differential would be Ebola, huh?
Yeah, there you go. See, I said easy answers, right? You're in an Ebola treatment center. Maybe this kid has Ebola. Great. Think basics.
Could there be some severe dehydration issues or malnutrition issues?
Absolutely. Yeah, that's great. So no matter what else he has, he probably is malnourished just based on the setting. And yeah, he's been vomiting for days, and the parents and families don't often have the education and resources to know how to deal with that. So he's probably dehydrated. Good. What's a big buzz one? Someone comes in with abnormal vitals, hypoxia, tachycardia, tachypnea. If you were in the ER, this person's going to immediately get flagged for something.
We have a lot of first years too, so
A lot of first years. Okay.
yeah,
Maybe.
and they just started their medicine blocks, so
Got it.
Having an MI.
An MI. If he was older than 12, I'd be thinking more along those lines. But kids he could have an undiagnosed heart issue, sure. How about sepsis? So that's the one, right? Like in the ER, this kid would be a code sepsis. We'd immediately be starting fluids and antibiotics and all of this stuff, right? So that would be a big one. Let's go a little easier. What do you want to know? What diagnostics, what resources, what do you want to do for this kid? What do you want to find out?
Maybe a blood test to rule out infection.
Okay. Yeah, it would be great to get some blood counts. How about a chemistry panel? What's his kidney function? All that good stuff. You're not going to, by the way, because you're at an Ebola treatment center in the Democratic Republic of Congo. So I'll throw over to a picture here. So this is a little better picture of like the center on the right-hand side, like you see the kid being let in. So our front rooms were what we called like kid row, because we could see and talk to the kids when no one was actually dressed up in full PPE and inside. So this was how I was treating this patient. I was standing 3 feet across the fence, examining the patient and asking the nurses to do things for me. We did have some basic blood work available that we could send out to the local hospital lab, but we wouldn't get it back to the next day. So we were drawing blood, but that information was not going to be very eminently helpful. And to throw in a little extra fun on this case, I was actually getting ready to leave. So this was my last day at the Ebola Treatment Center. I had to get on a Jeep in an hour. So you can see what the PPE looks like to go in to the Ebola Treatment Center. It takes, a good 15 minutes to don and a good 15 minutes to doff. And there was it just wasn't feasible for me to actually go inside and examine or treat the child myself. So that's just a little extra wrench in the case, and very difficult, right? I was watching this kid labored, breathing, in obvious, very bad shape, and my heart wanted to go in and do something. I knew that I was the person on site with the most skill and knowledge, and I wanted to get inside, but I couldn't. So yeah, so I would love to have like a CBC and a chemistry panel, but that's not going to come back till tomorrow. But I can get a glucose. So we did have glucometers. So it turns out this kid's blood sugar was 400 something. So now any thoughts about what might be going on?
DKA.
There we go. It came from our non-medical person. So I suspect that he had like late onset diabetes that he hadn't previously been diagnosed with. That was my suspicion at the time. Even our glucometers were horribly and notoriously inaccurate. So that was my guess. Okay, I realize a lot of you guys are first years, so you may not know, but I'll just throw it out there. And if nobody has an answer, that's fine. Any treatment you'd like to start?
Maybe give him insulin.
Okay, sure. Yeah. If his blood sugar's high, insulin would be great. What else? Look at his vitals. We don't need to know anything. What's the first thing you're going to do in response to those vitals?
Give him oxygen.
Give him oxygen. Unfortunately, you don't have any. That's not an option. You also don't have insulin. So we're left with fluids, right? So fluids can drive down your blood sugar, and that's a huge problem with a lot of the metabolic disturbances that are happening in DKA is the dehydration. So fluids actually are a huge part of the treatment. Just working here in St. Louis at an inner city ER where we were often very overcrowded, I would have to take care of patients in the hallway sometimes for 2 or 3 hours before they'd get a room. And I would treat my DKA patients with copious fluids when they didn't have enough monitoring and nursing support to start their insulin drips, until they could get into a room and on a monitor. So fluids can make a big difference. So, I started pouring fluids into this kid, but obviously to really correct everything, he needs good lab work and he needs insulin. But being in an Ebola treatment center, very much in the middle of nowhere, you're very, very limited in what you can do for a patient, partly just because of the PPE. And the number one problem is staff safety. So every time you stick a patient, every time you keep a staff member inside the unit longer, you're putting them at risk of getting Ebola, which then puts the rest of the staff at risk of getting Ebola. And so the very difficult thing about an Ebola treatment center is your number one goal is not taking care of your patient. Your number one goal is keeping anyone else from getting Ebola. When you're dealing with a disease that has over a 90% mortality rate without treatment and rapidly spreads, it really changes the situation. And so our treatments are very limited. Every Ebola patient gets broad spectrum antibiotics. So this kid was started on antibiotics. They're put on anti-malarial. So that's another one. So you have to think about your setting and know your setting, right? So the Congo. So this kid very likely could have had malaria or cerebral malaria. That could have been the cause of his altered mental status, is that he had, the malaria can spread and cause a lot of cerebral edema. And those kids don't do well. So he could have had cerebral malaria as well. He could have had multiple things going on at once. It's very hard to say. The end result of this case that was very difficult for me was that I had to leave, number one. And I knew that the national doctors just didn't have the skill and training to know how to improvise and take care of this child and possibly give them a chance. Which would be very hard to do with the resources we had, period. And the truth is, how much brain damage did he have from his oxygen levels being low for so long? Was this kid going to do well if he did improve and wake up and go home, with so little medical resources? I mean, those are the hard facts of the situation. I tried to continue to give input into the case by text message as I could. But again, the resources were slim and there wasn't much to do. And the very, very sad and difficult ending of this case, he made it through the 3 days at the Ebola treatment center waiting for his Ebola testing. So you have to have 2 negative tests 48 hours apart to be discharged. And so he was there for 3 days waiting for his 2 tests. They both came back negative. He was put in an ambulance to be sent to the hospital for other treatment for whatever else was going on. And he unfortunately passed in the ambulance on the way to the hospital, which was obviously a very difficult timing and very difficult for my coworkers here taking care of him. And so it's easy to see, right, how these types of situations can cause moral injury, right? And can cause traumatic grief is another term that I didn't have on the slide, but this traumatic grief, which is just a normal grieving response to a difficult situation. Yeah, we grieved over this child and his suffering and his parents' grief over losing their son. And so that traumatic grief. But, ultimately, I walked away from that situation feeling very grieved, yes. And it's something I've thought about many times. Why was I leaving that day? What could I have done, to help that child if I had been there and been able to drive and direct his care? But ultimately, that was out of my hands, right? And he could have been brought in at any time. He could have been brought in the day before, 2 days before, whatever, but he came in the day that I was leaving. And so just having to accept that I was removed from the situation and there was nothing I could do. And there's no practical reason for me to bear the outcome of that situation that I wasn't even present for. But what are the kinds of things that can cause, this moral injury? So self-induced. So it could be that we make an error or we perceive that we had a lack of skill. I'm sure most of us, if we've been in clinics, clinicals or whatever, we may have those situations where we feel like I did not have the skills and the knowledge that I needed. It's easy to feel that way, in these situations where there's no help to turn to, right? You don't have a consultant and specialists and, this whole hospital of resources at your hand. Moral injury can be others induced. So someone else takes or omits an action that betrays what I perceive is right. Being forced to take an action foreign to our training or experience. So sometimes, in other countries, they handle things very differently than we do. And so we might perceive the care as being inappropriate. Bedside conflict. If you've been in clinicals at all yet, you know that patients get angry, right? I mean, how many of you guys have experienced an argument or a patient that's angry at you or upset with the treatment plan? Maybe they're upset because they're not getting pain medicines, or maybe they're upset because they've been waiting too long, or they just they don't want to do the treatment plan that's been recommended. And that can be very wearing, especially in the ER. We deal with that constantly. Everyone's frustrated all the time, and often not very thankful or grateful for the services you're providing, and often very upset. And so, you can take that on as you've done something wrong, and that's why this conflict is happening. Or poor supplier equipment. Obviously, that played into a lot of situations at the Ebola Treatment Center, is that we didn't have, equipment and resources that we would like to have. But what's protective against this? And I kind of already mentioned this, and that's like a practical understanding of the reality involved. So we had lots of situations like this kid. So what was really hard about having this kid or other patients like that as an Ebola suspect is they may not, or even sometimes we were pretty sure they probably do not have Ebola, and we cannot provide them all the treatments that they need here at the Ebola Treatment Center, but we have to keep them here until we get the Ebola test back. And sometimes even the local health officials would be pushing us, well, just send them to the hospital. But we had to make that difficult decision and keep that hard standard of anyone that meets the definition of, the Ebola case definition has to stay here until they have 2 negative tests. Because while we may risk harm happening to that one patient, it's much more risky to send someone to the local hospital and then they end up having Ebola. And now Ebola has spread to the healthcare workers and the patients at the hospital, which we watched happen over and over again. And so having that practical understanding of the reality involved, that my main job is to protect the entire community, not this one patient, made those decisions for me personally not that hard. Yes, the decision itself, the outcome of the decision was hard, but the decision itself was not hard because, we as medical providers, we are putting ourselves in a position to make difficult decisions for other people, and we are choosing to bear that responsibility. And so being prepared and preparing ourselves mentally to deal with that, I think, is really important. And just keeping in mind that, am I improving the status quo? So the truth was, I visited the local hospital, and the care there was, even though they had more medicines available to them, the care there was probably of a much lower quality than what we were offering at the Ebola Treatment Center. And so at times when I felt really bad about not having resources to provide a patient, I reminded myself that I was providing a better level of care than any local resource that was available to them. And so even though it seemed like the ideal situation would be to send them out of the Ebola treatment center to a hospital, I was probably providing a better level of care. And so keeping ourselves grounded in those realities, rather than just letting the emotion of having empathy towards our patients, which is a good thing, carry us away, I think is very protective against that moral injury. And the other thing is that experience of knowing that I'm doing all I can. So, I talked a little bit about starting to get burnt out while I was working in the ER full time. Well, why? Because I never really felt like I was doing all that I could for my patients. I didn't really feel very connected to them. I didn't really I felt like everything was much more resting on a physician supervisor or the hospitalist I was admitting the patient to, or the consultant that I was passing the patient on to. And I was just trying to meet my administrator's goals of seeing patients within a certain time frame, of having my patient rate me with a certain satisfaction score. All of these things were weighing on me versus me taking care of my patient and really being committed to my patient. It's all this, there's all this framework in our healthcare systems, right? But when I get out to a field hospital in, the Ebola treatment center, or a mission clinic in the jungle in Liberia, now I know that I'm doing everything I can for the patient. Even if it's not enough, it's everything that's available. I am putting my full self into that patient, and I'm taking that full responsibility, and I'm going to do everything I can. And so at the end of the day, I can walk away from even a bad outcome, feeling confident in myself, in my purpose, in my passion, in my commitment, and that sense of responsibility that I did everything I could. I can't always control whether the outcome is good or bad, but I did what I could for the patient. And so I think what I want to suggest to you guys as you enter your careers to avoid this phenomena of moral injury, of burnout, of people leaving the field of medicine, the road to resiliency, I think often where we go wrong is we avoid the difficult situations, right? That would be so hard to be in that jungle clinic where a kid was dying of malaria and I had almost nothing to offer them, or that Ebola treatment center where I had to watch someone die waiting for their Ebola test to come back instead of sending them to the local hospital. But I want to pose to you guys that the road to resiliency isn't in avoiding the difficult situations, but facing those very situations that we're afraid of. That it's in entering the suffering of others instead of avoiding it. That when we connect, serve, and love in these difficult times and places, then we find this resiliency because there's so much purpose in that. There's so much passion in that. And we know that we are fulfilling our commitment, right? We all take that Hippocratic oath to be present for our patients, to do no harm, to do our best. And it's by entering in to that suffering and difficulty of our patient, by connecting with them, loving them, serving them to the very best of our ability, that we can walk away feeling confident about what we did, even if the resources weren't perfect, even if the situation wasn't ideal, and even if I believe that I could do better next time, right? If I know that I gave my all in this situation at hand as I could, then I get to walk away with that purpose and that passion that protects me. And that doesn't mean that I don't grieve those situations. It doesn't mean there's no trauma there to overcome, but it is overcomable, and I get to be resilient in that. That's the thing that keeps driving me forward, right? Is I know I have a calling and a purpose to help the suffering of others in situations where there is little to no other help. And so that purpose and that sense of calling continues to drive me forward. And I just want to propose that I think one of the reasons I've been talking about this, that we all get so burnt out in American medicine, is things like the electronic healthcare record, right? I spend more time with a computer than I do with my patient. It's this constant shift of responsibility. So if you're a student or a resident, you should be, but we're putting the responsibility on someone else. As a PA, I'm often going to my physician supervisor, or we're passing the patient on to the hospitalist or the surgeon, or we're just doing what the GI doctor said, or the consultant, whoever that may be. And those are all good systems that we have in place that provide excellent care and resources to our patients. But I think it does present this shifting of responsibility where I'm kind of constantly pushing off the burden. And rather than releasing us, I think that perhaps actually presents this moral injury. There's a lot of people out there in medicine who are saying, hey, you're calling us burnt out, but we're not burnt out. We're experiencing moral injury because we don't get to spend time with our patients. We don't get to connect with our patients. We don't get to provide what we think is right for our patients because we're doing what a large administration system has told us. And as I really contemplated this, I had this thought. If you've ever heard the biblical command, right, it says to bear one another's burdens. And it occurred to me that maybe God told us to bear one another's burdens, not just because it's critical for the people we're supporting and the people whose burdens we're bearing, but maybe it's actually critical to our own well-being, right? Maybe this practice of bearing others' burdens is actually crucial to me. Maybe like a muscle, right, that you strengthen through exercise, or a bone that can only grow stronger with weight bearing. Perhaps my own mental, emotional, and spiritual health strengthens with the exercise of carrying the weights for others. Right? So I want to say that again. Maybe just like a muscle that strengthens with exercise, or a bone that can only grow stronger with weight bearing, my own mental, emotional, and spiritual health strengthens with the exercise of carrying weight for others. Because I would 100% say that the reason I often felt burnt out walking out of my ER shift was because I didn't feel like I really got to help my patients. But when I go to a mission clinic or I go to a disaster response and I really get to enter into the suffering with my patients and really help them bear that suffering in the best way that I'm able, right, then I feel a sense of success, right? Then I feel that sense of victory, of mastery, right? If you guys have ever heard, they kind of say there's 3 keys to avoiding burnout: autonomy, skill mastery, and support. So we have to have a sense of autonomy, that we're able to make decisions. That comes hugely when you get outside of our classic, hospital clinic model. I have a ton of autonomy when I'm at a field hospital that I would never have in a regular hospital. Skill mastery. I developed skills that I never otherwise would, and I feel confident in those skills in a way that I don't back home, because I know that they're the best skills available in that situation. And then, support, having the resources, the leadership that we need, which can be a very tough one because often we're removing ourselves from resources in these mission settings. But so autonomy, skill mastery, and support are supposed to be the 3 keys to avoiding burnout. And so I just think looking for those opportunities to achieve that and to increase our skills in preparation for whatever unique purpose you find. So that's what I want to talk about. So what are the steps to building resiliency into your own medical career? And kind of based on going off of what I already talked about, these are the steps that I mentioned earlier that I wanted to kind of jump into a little more, but do hard things and go to hard places. I think that's kind of, I think I've made that point over and over again, is that we try to protect ourselves from these hard situations. And I think it actually does the opposite, right? Versus when we go to the hard places and we do the hard things and how that affects us. And there's a quote I came across while I was preparing for this that I want to share with you guys. It says, "When evil is unleashed, the man who does the most will always feel the worst, just as the man who feels the worst often stands the best chance of doing the most." So when evil is unleashed, the man who does the most will always feel the worst, just as the man who feels the worst often stands the best chance of doing the most. And that's interesting to think about, because it's, sounds a little counterintuitive to, feeling the worst shouldn't help with your resiliency, but we do have to feel, the weight of the injustice or the suffering that's happening before we respond to it. And so we do have to allow ourselves to feel those hard things and feel that suffering in a way that gets us to do something about it. And when we go and do those things, we will suffer through that. But instead of coming to that place of a lasting moral injury. You may have a moral injury that you have to work through. And we can instead foster something called traumatic growth, right? Something that makes us more compassionate people, better providers. I know I'm a much better PA. I know I'm much more compassionate towards my patients now than I used to be before I did all of these things. And so I just want to encourage you, don't be afraid. Do the hard things, go to the hard places, and start that now. If a lot of you guys are early on in your medical career, be the one when someone asks, hey, who wants to do this procedure? And you have no idea what you're doing. Be the one who jumps up and steps up your hand, up your hand and says, yeah, I'll try that procedure. I'll answer that hard question. And don't be afraid of failure, because if you're going to go to hard places and do hard things, you're going to do things you don't know how to do. You're going to do those things. For example, I was in a clinic. I was running a clinic in the jungle in Liberia, and someone brought in their 5-month-old baby. And so in Liberia, 5-month-old baby's even smaller than you think of it, because these kids are all malnourished. And they had an abscess right here under their chin. So we're talking over their trachea, right by their carotid arteries, worst place. And one of my trip providers at the clinic saw the girl, the little baby, and was like, well, you need to take them to the doctor. This needs to be drained. And I'm like, they're not going to, it was over an hour walk to get to a basic clinic that would not have been able to provide that level of care. I'm like, they're not going to go to the doctor. This abscess is just going to keep growing. It's going to cut off this child's airway, and I drained an abscess. I don't do pediatrics, first of all. I drained an abscess on a 5-month-old baby that was right over everything important in your neck. So incredibly frightening situation. But I started building those skills even in PA school by just saying hey, yeah, I'll do that thing. I might need help, I might need instruction, but I'll do that thing. And so I just encourage you, even now, start doing hard things, but also go to hard places. And then secondly is this idea of bearing one another's burdens. So I just want to encourage you, take the responsibility to make hard decisions when maybe someone else is struggling. Sometimes we have to make hard decisions for our patients, just like I talked about having to make hard decisions at the Ebola Treatment Center. But start putting yourself, making that practice of being okay with bearing the burden of making hard decisions. But also bear one another's burdens by entering in to suffering with your patients. So don't be afraid to take an extra minute when your patient is facing a really hard situation to just be present with them. Let them talk for a minute about what's going on or how it's affecting them. Cry with your patient, right? I've had that patient that just got the news that, we did a CAT scan in the ER and their cancer is worsening. Let them see that you care. Cry with your patient. Enter into the difficulties your patients are facing, whatever that means in this situation. Pray with them, listen to them. Just take an extra minute with them. Take an extra minute to explain to them what's going on. If you are a medical student, you actually are a great support to the patients, because a lot of times the doctors walk in and explain things in medical terms, and you can stay back with the patient and explain it in words that they can understand. You can be a great resource to your patient. And then finally, in this bear one another's burdens, I'm going to encourage you to support and be available to your peers. So they found this when we were in New York, right at the height of COVID, right? When I don't know if you heard, there was a big story about one of the emergency medical directors committed suicide. It was an incredibly difficult time. And what they found was the number one thing that was helpful to providers was a peer-to-peer support system. So getting support from their other colleagues and peers who were in the same situation was more helpful than getting professional counseling. Because you understand what's going on and you can say, yeah, it's okay to feel that way. I feel that way too. And so I really want to encourage you to be available to your peers, to get support from your peers, but really bear one another's burdens. And that could be even creating a formal process for that, and creating a formal space for that. And that'd be a great ministry to other students, to other residents, is to create a space for people to get peer support. So bear one another's burdens. And as you do that, I think you will strengthen your own emotional and spiritual health. And then here's a really big one: develop your personal philosophy of suffering. So when you face suffering, which you're going to do in medicine, whatever career path you take, how are you going to frame that suffering? So, what's the framework? How are you going to deal with that? Where does suffering come from? What purpose does suffering serve? So personally, this I know is super helpful and protective for me. My personal philosophy of suffering is I believe that I get to be a part of what God is doing when I go to these difficult situations. Suffering is the consequence of the fact that God has given us free will, and He doesn't force us to do what's right. But God is also good, and He loves us, and He wants us to have a relationship with Him. In fact, He wants that relationship with us so very much. He wants to fix the things, the ways that we bring evil into the world so very much that He sent His Son Jesus Christ to die for us, to take the punishment for the sins and the wrongdoing that I've done. Right? We all know there's evil in this world. It's very easy to see right now more than ever. But God wanted to end that evil so much that He sent His Son Jesus to die and take the consequences of all of that, and to come back to life, so that if we put our faith in Jesus Christ, He gives us a new heart. He gives us, a new ability to do good, to love others, and gives us a relationship with Him. And so I can believe in all circumstances that a God who loves me so much to do that loves me in all situations, that a God who loves the world so much to do that, even when I can't see why He's allowing this suffering to happen, I can believe that He's good, and I can offer hope to my patients. One of the very hard situations at the Ebola Treatment Center was a patient that came in. She ended up not having Ebola. She had late term HIV, and there was really nothing much at that point to be done for her. She came in so depressed and really suicidal that she wouldn't even take a Tylenol for her fever, or let us give her fluids, and Zofran for her vomiting, and she was so sick. But I was able to share with her the hope that I found in Jesus and in the love of God. And she found faith in that as well. And she died at the hospital a few days after we released her. But when she left us, she had so much hope. She left with a smile, knowing that there was a family of people there who cared for her, and there was a God who loved her. And so there was nothing I could do to change the outcome of her life or death, but I was able to offer her hope. And so that's where I find hope in suffering, is that God loves and wants to be in these situations, and I get to be a part of showing His love to others. But I just want to encourage you, read books on suffering, read Bible verses on suffering, figure out what your personal philosophy of suffering is, and prepare yourself for those situations. And I know we're running out of time here, so I'm just going to hit these last three really quick. Develop skill mastery. So whatever you want to do whatever it takes to get really good at it. And if you want to go do mission clinics around the world, develop skills outside of your main field. Get really good at your physical exam. Get really good at figuring things out when you don't have all the resources available to you that you would here. That's a huge one. Like, we're so reliant on diagnostic tests, but in that world, you have to be so reliant on your physical exam. So develop those skills. And then develop and maintain healthy habits. So that's kind of that self-care piece. I think you guys know what that is, but that's eating, sleeping, exercise. For me, it's very easy on a deployment. I'm often working 13, 14 plus hours a day. It's easy to let my time of prayer and time in the Bible go to the wayside. But then I realize that I'm actually only making things much harder on myself, that I'm not thriving. And I have to get back to those personal care habits of, spending time renewing and refreshing my mind by reading the Bible and praying. So figure out what yours are. Develop a support system. Who's going to check in on you when you're in the middle of those hard situations? Who knows how to recognize when you're not doing well? I have those friends who know that when I get home from a deployment, about 2 or 3 weeks later, I'm going to really be struggling, and they check in on me. And they help me make healthy choices to get out of that funk. So develop those healthy habits. And then the main thing that I want to encourage you guys is find your unique purpose. So outside of what, specialty am I going into, or what hospital am I going to work at, find something that really gives you passion. That's what's going to make you resilient. That's what I think has protected me from succumbing to those feelings of burnout, is I have that sense of purpose. So maybe that is doing international mission trips or disaster relief, but maybe for you, that's volunteering at a local clinic. Maybe you feel really passionate about the homeless population. Or maybe you want to be one of the people who gets involved in administration at your hospital and takes on some of the problems there. And you want to help improve some of the things that cause burnout, right? That could be your unique purpose. Serving and supporting other medical professionals, like I talked about, maybe some, peer support, whatever your calling is, figure that out and develop that and find a way to make your medical career uniquely work for you. It opens so many doors, right? How many careers are there that you could work on an as needed basis, right? So I work shifts when I can pick them up, pay my bills, and travel all around the world, right? I mean, how many careers can you do something like that? Like, your medical career opens such unique doors for you to have flexibility in your lifestyle, to fulfill your calling, your purpose, enjoy your hobbies, all of those things. It doesn't have to be this road to burnout that we so often see happening. So I think that's everything. And if you guys have any questions, please feel free.
Just being in our ministry for the last 5-6 years, I definitely can attest to what you just said about finding finding your passion and what's unique to you. Because like unfortunately, Karen and I both have seen several physicians that have faced tremendous burnout, and almost 99.9% it's because they chose that kind of life based on some other reason, as opposed to what they were passionate in, right? Like, I've heard some doctors tell me, I know what I need to make to survive. So he's locked into his job, even though he hates it, but it pays his mortgage, it pays for his kids' school and in life. And I think what you just said, my hope is that it would be an encouragement to our students as they begin their careers now, and just be thinking, have it on the forefront of their minds that passion is just so important. Like, do something that you're passionate in, rather than what everyone else is doing, or whichever pays the most, or there are thousands of reasons to, so but thank you.
Yeah, just a quick add on to that, Stan. I mean, in 30 seconds, my story was that, yeah, working full time in the ER, sure, I had a steady paycheck, I had benefits, all of those things that seem so important to security or happiness, but I wasn't, and I was on a mission trip, and I said, wait a minute, I love doing this, but I almost can never do it. And I really dislike my job and don't get satisfaction out of it. So why am I continuing down this path? And even though, like, month to month, sometimes finances are a little unsure, but like, my satisfaction and joy and happiness is so much greater because I know I'm doing what I'm passionate about, what I'm supposed to be doing. So I'd encourage you guys, yeah, don't be driven. I mean, we have to, be financially wise, but don't be driven by the money.
Thank you. Well, Shannon, would you like to close us in prayer?
Yeah, I'd love to.
Yeah.
Dear Heavenly Father, God, I just thank you so much for this time together, Lord, and I just thank you. It excites me to think about the journey that you have for each of the students that have joined us today, Lord, and that you called them to this career path. You called them, and you have a passion and a purpose for them. And so, God, I just pray that you would just help them to develop those skills and just find that path that will take them to a place of resiliency and purpose, God. Just that they will continue to find support in this group right here, and just encourage one another as they walk that path. Just help them with the practical realities of getting through medical school or residency, whatever stage they may be in. We just thank you again for this time together. In Jesus' name, amen.
Amen. Thanks, guys. Y'all have a great week. Drew, do you have an announcement or?
Come to Bible study. That's all I got.
Okay. Tomorrow at 8 o'clock. Yeah.
That's right.
Okay. Thanks, everybody.
Thanks, guys.
Thank you.